presented with this here, you can see there is evidence of ischemic changes in the temporal lobe, and this internal carotid artery injection shows less filling of the venous structure in the temporal occipital region. And certainly, this was an angiogram of external carotid artery. There's supply coming from middle meningeal artery, ascending pharyngeal artery, and occipital artery. Trans-venous branch of the occipital artery was major supply, and you can see the isolated sinus with the reflux to these cortical veins. So we decided to go with a transarterial. We catheterized with a septal balloon catheter. We went into the transvenous branch. You can see the catheter tip is in the intracranial space already, and we injected glue, and then this is not glue, onyx, and we were able to close it, this type of ablation by transvenous approaches. The onyx made a big contribution in treating this type of complex arteriovenous malformation of the dura. And certainly approaches has changed since the introduction of the onyx. Unfortunately, the guy who first introduced this onyx material never got credit. This doctor from Mie University in Japan, there's a guy named Warataki. Warataki is the guy who introduced this onyx material about 25, 30 years ago. Okay? He never really, got the credit of introducing this material, and he never really materialized it to clinical use that widely. Okay? Anyway, in the era of onyx, what is indication of the transvenous approaches? Especially, I do believe, just Timo mentioned, cavernous sinus dural AV shunt is the ones which is quite indicated to use transvenous approach rather than transarterial approaches because of very dangerous, very common anastomosis with ophthalmic or internal carotid artery. As Philippe introduced to you, the cavernous sinus can be divided into two major components. There is several different classification or compartments described in neurosurgery, but major thing is anterior inferior compartment and posterior superior compartment. Okay? And some time ago, many years ago, we were looking at the cavernous sinus dural AV shunt. We recognized there is an anterior inferior compartment AV shunt and posterior superior compartment AV shunt, two different locations. The anterior inferior do have ipsilateral supply, but venous outflow was only ophthalmic vein. Okay? There's no PL venous drainage or inferior petrosal sinus venous drainage. However, posterior superior compartment has bilateral supply often, and there's a supply, the venous outflow to the PL venous drainages, middle cerebral veins as well. Okay? The example is that this is one of the anterior inferior, which is, say, only ophthalmic vein venous outflow, and this is posterior superior compartment. You can see the bilateral supply. You have to recognize often, most of these, as I show you, 30-some cases of posterior superior compartment, we had only one case of bilateral cavernous sinus shunt. Even though you may have bilateral supply, and usually shunts is one side. This is one of those cases which has bilateral supply, bilateral venous outflow to the ophthalmic veins. Okay? This is one of those cases which can have bilateral supply. You can see supply coming from the both right and left internal carotid artery as well as middle meningeal artery supplies. This is the image I showed you before. You can see the collateral supply coming from contralateral internal carotid artery through the clival anastomosis behind it. Venous approaches first introduced is Sean Mullen. Sean Mullen is a neurosurgeon. He was chairman of the University of Illinois in Chicago. He was the guy who actually believed, it's not guy, but he's a professor who insisted this AV shunt lesion is venous disease and not arterial disease. Okay? An actual treatment of dural arteriovenous shunt by venous approach is the Grant Hishima's group. They introduced, first published in 1989, how you can treat by going through the inferior petrosal sinus and packing cavernous sinus with the coils. So that was the first introduction of endovascular treatment of dural shunt transvenous approaches. And cavernous sinus lesions, we treated 26 of those cases through the venous approaches. 23 cases were inferior petrosal, 2 was ophthalmic, 1 was through the foramen ovale, going through the pterygoid venous plexus. And among those cases, only 14, okay, had a visible inferior petrosal sinus on angiogram. Angiogram showed that the root of the inferior petrosal sinus. The rest of it, we couldn't see it. 18 of the cases we couldn't see, but we were able to go through the occluded segment of the inferior petrosal sinus, but 7 of the cases we couldn't do it. This is certainly easy if you can see inferior petrosal sinus go through the jugular vein and reaching to the cavernous sinus relatively easy. Once you reach it, you have to look at venous outflow. If there is a pure venous outflow, you will have to close it, the orifice of the venous outflow to the pure vein first. Otherwise, you can make it condition worse. So we are able to close this orifice of this middle cerebral vein, and we were able to close it, this shunt, by putting the coils in the cavernous sinus. And I prefer to use it as fibered coils. And this is a fibered detachable coil. Used to have it. I don't think they produce anymore. And there is a short fibered coils. You can use it cheap. Instead of $2,000 coil, you can use $100 fibered coils. Multiple coils can be replaced. This is again case of the inferior petrosal sinus is not opacified, but we were able to go through the inferior petrosal sinus, occluded inferior petrosal sinus, eventually go through this occluded segment and reaching to the cavernous sinus this way. And you can see the venous outflow to these middle cerebral veins. This was occluded with detachable coils, combination of detachable coil and fibered coils. Fibered coils has a Dacron fiber is attached to the coils, so it's more thromogenic than just a platinum detachable coils things. So this is before and after treatment, you can do it. This is one patient who came from China. She was 59 years old. She was treated in China and then somehow conservatively managed in China, but she lost the vision on the right side, and her vision on the left side was deteriorating, and so she came to US, and initial CTA shows dilated vein on the left side, okay, and the actual shunt was on the right side, okay. So this was an angiogram we performed, and you can see the internal carotid artery is filling, and shunt is draining into the left cavernous sinus and draining into the left ophthalmic vein in this way. And shunt is actually located on the right side. We tried to go through the inferior petrosal sinus. Okay, this is for the angiogram showing it. And we failed to go to the inferior petrosal sinus on the right side. So the only option was we tried to go the opposite side, or otherwise surgical embolization. So we found the route. We were able to go through the inferior petrosal sinus, but it's crossing the cavernous sinus to the opposite side was not easy. You know, there is a coronary sinus called coronary sinus anterior and posterior to the sella tussica, connecting both the right and left cavernous sinuses. That's why sometimes this shunt is on the opposite side, but symptoms could be ipsilateral side as well. So we struggled, and eventually was able to go into the coronary sinus and go to the opposite side of the cavernous sinus. You can see the very small channel. So we were able to close it, and this shunt was closed successfully without going to surgery on this specific woman. Okay. How about the transvenous sinus, transvenous approaches? Okay. And when you evaluate transvenous sigmoid sinus, you have to know exactly what the symptoms are. You have to evaluate whether this is benign or aggressive. If it's benign lesion, just what Carol introduced to you, you may observe it or conservative management. But if PL venous drainage, you have to go more aggressive treatment. The goal should be more cure rather than palliative if there is a PL venous outflow. The question is, which route do you take? You can use it, now with the onyx, mostly arterial, but sometimes you may need some venous approaches to treat such complex lesions. Okay? And when you choose a venous approach, certainly you have to know how rest of the brain drains. Okay? Timo showed you problem of the occluding normal venous outflow. So you have to certainly evaluate how rest of the brain drains. Okay? And also you have to know exactly where the shunt is, shunt location. Okay? If you needed to occlude this transverse sigmoid sinus, you have to know where the shunt is, and you have to close the inflow from the shunt to close it off. Okay? And also how the rest of the venous sinus is. If its opposite side is occluded, you cannot occlude ipsilateral, otherwise you will cause venous hypertension. This is especially, shunt is where? It's not directly into this transverse sinus. This is small, shunt is more at the wall of the sinus and draining, where's my, okay. And it's not directly draining the PL veins, so these kind of things may be better to go to the transarterial rather than reaching the transvenous. There's no way you can reach transvenous. Okay, you can see the patent transverse sigmoid sinus of this specific patient. Okay? And this is one of those patients. Okay, you can see this venous hypertension, and the angiogram shows simply isolated venous outflow. Okay? You can try to get into occluded segment. However, it may be easier to reach transarterially rather than transvenous. Okay? And also, you have to remember there are septations in the sinuses. Okay? First, Ronnie Piskey published many years ago and septated a segment of the dural shunt. Okay? Rather than occluding whole sinus, you can see this is a specific case. There is a shunt, is a more inferior, smaller shunt channel. So what we did is we went to the smaller channel. You can see this separate this normal venous outflow versus this is where the shunt is, and we were able to get into that where the shunt is. You can see the septation in between these two segments of the sigmoid sinus, and we were able to close it, this shunt, by occluding smaller channel of the shunt. Okay? And also, this is one of the complex cases. You can see the patient presented with left third node palsy. Okay? And we were referred to treat this anterior communicating artery aneurysm for the third node palsy. Is it correct? This aneurysm will not cause a third node palsy, right? So we did a further study. There's a certain AV shunt in the cavernous sinus. So we treated this cavernous sinus, okay? And because of aneurysm was quite complex, she underwent surgical clipping and successfully clipped aneurysm, broad neck, complex shaped. And this was a 1 year follow-up CTA examination. What do we have? We have a multiple dilated vessels, okay? All over the left side as well as the right side. And this is angiogram what we did. Angiogram shows certainly she developed, meanwhile, this complex dural arterial venous shunt with occlusion of the distal sigmoid sinus. And you know, this is about the time in the Onyx was popularized, but in case we decided to go to transvenous, we go through the opposite side and catheterized, and this transverse sinus with the septation. It was very difficult to locate where exactly shunt is, so we decided to occlude whatever we got in. Okay? Fortunately, we were in the right channel to close off. By closing this segment of the shunt, I mean the septated sigmoid sinus, we were able to close this. Okay? Some other lesions, if you look at the analyzed angiogram very well, you may be able to treat simpler way rather than using complex catheter and complex onyx injections. This is old case, but if you look at an angiogram, what do you think? There's a middle meningeal artery supply to this is shunt. Occipital artery supply to the shunt. If you look at angiogram very carefully, shunt occurs this spot, right? So we got into the vein, we catheterized this pocket, we just put a few coils. This is after treatment. Okay? Certain dural shunt is one spot. Okay? Just like showing in this case, you have to analyze angiogram very carefully to have effective treatment. This patient, where's the shunt? Shunt is here, right? Separate channel. There's another channel of sigmoid sinus. Okay? Unfortunately, this patient underwent treatment, another institution. What happened?
They called the normal channel.
They called the wrong channel. They called the wrong channel and they left this channel with the shunt open. Okay? This is what it is. Okay? So you do have to analyze angiogram very carefully, not only when you go to the transarterial, same as the transvenous approaches, you have to analyze it carefully. Other locations which indicated to have a venous approaches is osteodural lesions, especially in the skull base osteodural lesions. You can see this shunt occurs at this condyloid vein. This is more of I think hypoglossal. Is it jugular? Maybe jugular fossa. Okay, this was a supply coming from occipital and ascending pharyngeal of this. No, this is hypoglossal. I'm sorry. Okay. This lesion was treated with transvenous approaches. Okay, this was successfully closed. This was another case. Okay, you can see this is jugular fossa, AV shunt, osteodural lesions of the jugular foramen, supply coming multiple external carotid and vertebral artery supply. And this patient first went to the different institution, very prominent institution in the United States, and they approached the transarterial approaches. You can see the onyx cast of this, and patient was told that she did the 6 separate treatment sessions for this treatment of this osteodural lesions. But she came, referred to us, and selective injection certainly shows, you can see the shunt as posterior condyloid vein and going into the jugular vein, and this is multiple feeders and ascending pharyngeal artery as well as contralateral ascending pharyngeal artery through the multiple channels, internal carotid artery even give the supply to these lesions. So we were able to go through transvenous and put in coils. You can see the cast of the coils, okay? And we were able to shunt completely. Recently, I had this interesting case. You can see this multiple small kind of a body defect in the clivus as well as the odontoid process, and This is the MRI, and selective injection shows supply is coming from contralateral, ipsilateral, ascending pharyngeal artery, and vertebral artery. And this was a hypoglossal canal, AV shunt, and draining into anterior condyloid vein to the jugular vein. Okay? You can see the 3D image of the ascending and the C3 anastomosis going into the shunt of the lesion. Okay? So we were able to go to the transvenous approaches and able to close it. So osteodural lesions at skull base is certainly indicated go through the transvenous approaches. These are, I believe, the indications to go through transvenous cavernous lesions and selected cases of transverse sigmoid sinus dural AV shunt and osteodural AV shunts. And I'd like to show you a few cases of some unusual cases we did transvenous approaches. This is an elderly patient who presented with a subarachnoid hemorrhage, and you can see the shunt is middle cranial fossa. And it was so difficult to catheterize. You can see the catheter position in the brachiocephalic artery, and the catheterization was almost impossible to get to the internal, even the internal carotid artery. So this is how you can see the jugular vein, sigmoid sinus, okay, going through superior pleural sinus and the middle cranial fossa. So that's what we did. We got into this shunting area, and we were able to close it just as venous approaches and putting the few fibroid cords in there. Okay, this is a case which is very complex. We thought we can go to venous, the septated area of this sigmoid sinus through these transvenous approaches. You can see the venous drainage in the jugular vein and go down. And unfortunately, at the time we did the angiogram, we didn't evaluate the distal portion of the jugular vein. And when actually we went to the vein treatment, we couldn't find the jugular vein. Meanwhile, from the angiogram to this treatment sessions, the internal jugular vein was completely occluded. So we had to find other routes. We were trying to go to different channels, and fortunately, we were able to go to this paravertebral venous channel and getting into this internal jugular vein this way, and we were eventually able to treat these lesions. Okay? And bilateral dural shunt and P2 segment. This patient has bilateral lesions. You can see this. This is a right side and left side lesions. Huge venous aneurysm in this case. We did transarterial approaches with glue first because this is before era of onyx. Okay? So we did as much as we can, and because of the extensive PR venous outflow, remaining part we sent for the surgery. The surgery is relatively easy, for especially this P2 segment, P2's rich arteriovenous shunt. Okay? So he went in and he clipped this draining vein and cauterized some of the arterial side, and it was closed. Unfortunately, patient got hearing loss. Probably during the coagulation, some of the arterial supply to eighth nerve must be closed off. So because of the hearing loss, we were afraid to send this remaining part on the left side to the surgery again, and our surgeon was said, "I'm not going to surgery. You take care of it." So transarterial was quite dangerous at this situation. Remaining supply is coming from the internal carotid artery, so we decided to call transvenous approaches. Since the venous aneurysm was shrinked, smaller than the initial angiogram, and we thought maybe possible, even though it's a higher risk, maybe rupture the PL veins, but we were very careful to go into it and eventually reach it at the Peter's reach, and we placed two detachable coils, and this is after the treatment. Okay, some cases, you may be forced to go to the transvenous approaches. This is after the treatment. How about this case, the initial case I showed you? This is isolated shunt. I tried to go to the occluded segment, but guide wire went in. I couldn't pass the catheter. Okay? I forced, and I couldn't, and I gave up. And we decided to go intraoperative. This was a case I treated 1992. When I first went to the Mass General from New York, and this case was waiting for me. He underwent multiple embolizations, transarterial embolization with the glue by my predecessor, and this is the remaining part of the shunt. Okay? And I debated what to do. There's no arterial route to reach this one, and glue was all over to the feeding arteries. So the idea was maybe I can go into the the transvenous approach through the intraoperative. So I asked a surgeon to expose this transverse sinus where the shunt is. This is catheter putting in the sheath, and through the sheath we placed the coils. This was, as you can see, this is November 1992. Okay, we were able to close this way. So same thing, this impossible case, I asked a neurosurgeon to put this, make a burr expose the transverse sinus, and we catheterize it and we put in the coils, and this was, we were able to treat it. Okay. Last part of this talk, what can go wrong if you go to the transvenous? Okay. You can make it, this is symptoms, if you, as I mentioned before, if you don't close venous outflow to the important vessel, important veins, you may make a patient worse. This is one of the example, many old case, and we had an incomplete outflow, the embolization of this shunt and clivus. Okay, you can see next day his eye got worse because the outflow to the jugular vein was closed, unfortunately, but venous outflow to the ophthalmic vein was open. So we didn't close that, so that's why the patient got worse. This is another case. Patient had the cavernous sinus shunt, and you can see the ophthalmic vein is opacified, and in addition, you can see this superior petrosal sinus, okay, is a little bit opacified. I got in transvenous, and I was closed, okay, combination of detachable coil as well as fiber coils, and this is final angiogram. Final angiogram. I tried to go last piece of this is cavernous sinus, but catheter was kicked out. I couldn't get back this point, and I thought that this would close. Okay, this vein is relatively stagnant, so I thought it would go away. However, patient has severe dizziness and nausea, vomiting next day, and we did MRI. MRI shows ischemic changes of cerebellum and vermis as well. An angiogram shows this little bit remaining part is causing venous hypertension in the cerebellum through this, petrosal vein, which is draining this portion of the cerebellum. The only arterial supply remaining was this one. This is contralateral, okay? Contralateral distal external carotid artery. You can see small branch crossing the over opposite side and filling cavernous sinus and filling this draining vein. How we can reach it? Old days we used to use a sandwich technique. Okay? With a microcatheter, distal part of you fill the microcatheter with the dextrose, and then you put the little 0.1 or 0.2 cc of glue in the catheter. Catheter volume, microcatheter usually 0.15 or 0.14 inch microcatheter, okay, have a 0.3 cc of volume. So you put it on 0.1 cc of glue, load it, and push with the dextrose to deliver this glue to distally. Okay, that's how we did it, and this was able to close the venous outflow of this lesion. Okay, and that was a final result, and patient had resolved and a little leaving a little infarction in the cerebellum, a little bit. Okay, this is a patient who had a multiple episode of dysarthria, and as you can see the symptoms, and certainly patient had this the dural shunt and transverse sinus. Okay, supply is coming. You can see from the tentorial branch. Okay, and there's a supply. Look carefully. Supply coming from posterior cerebral artery branch. Okay. There's a superior cerebral artery branch a little bit reaching the shunt. Major supply was coming from the occipital arteries and middle meningeal artery as well. Okay. And we treated trans-venous and getting into the arterial side first stage, and we did multiple holes, closed off, but unfortunately this was remaining. At the second stage, okay, you can see this persistent supply coming from posterior cerebral artery. Okay? So we decided to completely close this transverse sinus. Okay? We closed all this, and we were able to close off everything. Okay? And you can see the stagnation of contrast material in this sigmoid sinus. It means the shunt is closed. And we had I don't know how many, 48 coils. Okay? And this is final angiogram. You can see final angiogram shows stagnation of contrast material in vein. Okay? And you can see there's a hyperemic area in the occipital lobe. Okay? This is opposite side. I was afraid to closing of this draining veins, vein of Labbe and vein of Trollan on both sides. You can see the stagnation of the vein. So I put it on heparin, a little bit of low dose heparin, and she was fine first day, and second day, early in the morning, she had a transient episode of no responses. And about 4 a.m., she lost completely. Okay? She lost consciousness completely. And we got the CT scan immediately. This is CT scan. She had a massive bleeding into the occipital lobe and parietal lobe. And I called the surgeon immediately, and he was dragging on, and he operated around 7:30, okay? And when he opened, he got into it, he said, there's a posterior cerebral artery branch that is pumping blood. Okay? The lesson I learned from this, okay, fortunately she kind of recovered most of the neurological deficit. What did I learn? If you have arterial supply coming from PL artery, you have to close PL artery first. Okay? Just like a brain agent can have a collateral supply coming from dural arteries, dural IV shunt can have arterial supply coming from PL arteries. So in case of PL anastomosis, PL supply, you have to close those first before you go to the sinus or other transarterial supplies. Okay? Thank you very much. Any questions?